welcome to today's webinar, Transitions in Care for Youth with Psoriasis. My name is Bev Bromfield, and I'll be your moderator for today's presentation. To help guide you in how to participate in today's event, we've taken a screenshot of the attendee interface. You should see something that looks like this on your computer desktop in the upper right corner. You've joined this presentation using your computer speaker system by default. This means if you hear music through your computer, you should be able to hear the presentation. If you prefer to join over the telephone, select Use Telephone in the audio pane and the dial-in information will be displayed. You'll have the opportunity to submit questions to today's presenter by typing into the questions pane on the control panel. You can send your questions in at any time during the presentation. We'll collect these and address as many as possible during the Q&A session with today's speaker, pediatric dermatologist, Dr. Adelaide Hebert. Before we begin, I'd like to acknowledge and thank our sponsors, Amgen, Janssen, Lilly, and Novartis for their support of this webinar for parents and youth with psoriatic disease. Since some of you may be new to the foundation, here's a little background about who we are, our mission, and what we do. For over 50 years, the National Psoriasis Foundation has served the more than 8 million individuals in the U.S. living with psoriasis and psoriatic arthritis. Founded from a tiny classified newspaper ad in Portland, Oregon, the NPF mission is to drive efforts to cure psoriatic disease and improve the lives of those affected. After completing one of the most ambitious strategic plans in its history, the National Psoriasis Foundation launched a new 5-year strategic plan on July 1st, 2019. With a continued focus on a life free of psoriatic disease and its burdens, NPF remains committed to finding a cure for psoriasis and psoriatic arthritis while supporting individuals to live longer and healthier lives. Over the next 5 years, NPF will focus on achieving 3 goals: to lead collaborative transformational research in psoriatic disease, increase the lifespan and health of individuals living with psoriatic disease, secure the human, technological, and financial resources necessary to achieve NPF's mission-related goals. By attending today's program, you've already taken a step towards expanding your knowledge about psoriasis and psoriatic arthritis, moving towards a better understanding of what it means to live with psoriatic disease. A few of the many ways that NPF supports the goals of leading collaborative transformational research includes, to date, NPF has funded over $24 million in grants and fellowships. That includes over $3 million in grants and fellowship funding announced this summer. NPF grant mechanisms support all stages of research and careers. Our efforts focus on areas of unmet needs and are often conducted in partnership with research stakeholders with whom we collaborate. In addition to funding outside grants and fellowship, the NPF also leads research initiatives such as the Psoriasis Prevention Initiative and the Psoriatic Arthritis Diagnostic Test Grant, which are new to the Foundation. The Psoriasis Prevention Initiative was developed at the recommendation of the Psoriasis Prevention Initiative Steering Committee, who urged a definition of prevention to better guide the proposal development, and that's how it expanded to disease relapse and comorbidities. NPF plans to invest $6.5 million over 5 years in this effort. The second initiative is the Psoriatic Arthritis Diagnostic Test Grant, which aims to develop a diagnostic test for psoriatic arthritis. This could significantly reduce the time between onset of symptoms and a diagnosis. This is important because we know as little as 6 months of delay between onset of symptoms of psoriatic arthritis and start of treatment can lead to permanent joint damage. This slide highlights 4 NPF research efforts that you can be part of. Launched in 2015, the NPF Corona National Psoriasis Patient Registry is the largest independent observational registry of psoriasis patients in the United States. The registry collects and studies patient health information, allowing researchers to compare the safety and effectiveness of psoriasis treatments, better understand conditions that are related to psoriasis, and explore the history of the disease. There are currently more than 11,915 patients enrolled at more than 270 sites across the country. Your dermatologist may be enrolled as an NPF Corona National Psoriasis Patient Registry site. Not sure if they are? Ask. If they're not, encourage them to join. The LIGHT study is a real-world research study that compares the effectiveness of home versus office-based UVB phototherapy treatment of psoriasis. Entry criteria for the study are simple. You must be age 12 or older, have plaque or good-tape psoriasis, and be a candidate for office or home phototherapy. There's no washout for topical, oral, or biologic medications, and the study is designed to be easily incorporated into routine patient care. It is also unique because it includes equal representation of all skin phototypes. Citizen Scientist is a platform where you as a patient answer survey questions which you and researchers can analyze for trends and new insight. Citizen Scientist is currently being revitalized for greater community benefit. The NPF Annual Survey is a data collection effort the Foundation has conducted for 2 decades. This important research conducted each fall provides insight into the lived experience of individuals with psoriasis, including quality of life and unmet needs. If you're contacted about this annual survey, we'd appreciate you sharing your experiences with us. To achieve the Foundation's goal as mentioned, please support our mission through donations or by participating in virtual Team NPF events such as Stamp Out Psoriasis, Walk, or Cycle event. You can learn more at psoriasis.org/donate or teamnpf.org. On behalf of the National Psoriasis Foundation, thank you for attending today's webinar. Well, you'll learn more about when it's appropriate for a child or teen to become more responsible for their psoriasis treatment plan or medical care and what those responsibilities could be. Tips on how to make those transitions from parent to child or teen occur and what factors should be considered. You'll also learn about the AAD-NPF Pediatric Guidelines for psoriasis and what they mean to you as a parent of a child with psoriasis. Additionally, resources to help gain a better understanding of psoriatic disease and available treatment options. Now I'd like to introduce you to our speaker, pediatric dermatologist Dr. Adelaide Hebert. Dr. Hebert is a professor of dermatology and pediatrics at University of Texas Health McGovern Medical School in Houston. Dr. Hebert has also been the chief of pediatric dermatology at McGovern School of Medicine and Children's Memorial Hermann Hospital for over 30 years. Dr. Hebert's clinical interests include psoriasis, atopic dermatitis, lupus, wound healing, and other diseases of the hair, skin, and nails. Dr. Hebert is actively engaged in dermatology clinical research with a strong focus on psoriasis, atopic dermatitis, and hyperhidrosis. She is a fellow member of the American Academy of Dermatology, American Academy of Pediatrics, American Medical Association, Texas Dermatological Society, and past president of the Women's Dermatologic Society and past president of the Society of Pediatric Dermatology. Dr. Hebert is also a professional member of the National Psoriasis Foundation. It's my pleasure to welcome Dr. Adelaide Hebert, who will present today's webinar, Transitions in Care for Youth with Psoriasis. Please welcome Dr. Hebert.
Thank you, Beverly. It's a privilege to be with you today. I wanted to share with you my disclosures. I have done considerable research in the arena of psoriasis, both in adults as well as in children, but all of my research funding is paid directly to the medical school. I want to give you first an overview. We're going to talk a little bit about science in terms of scientific data that's published and so forth, but I'm also going to talk a great deal just from my experience as being the only pediatric dermatologist at my medical school embedded in the largest health center in the world in Houston. We're going to talk about pediatric psoriasis in general. Many clinicians actually are not aware that there are about 20,000 children less than 10 years of age diagnosed with psoriasis in the United States every single year. So this is really not an uncommon disease. It's something we see actually quite frequently, and I think it's actually increasing in the population. Bev mentioned that this is a chronic multi-system inflammatory disease, and about 1% of all the children in the United States are actually affected. The most common time where we see onset is during adolescence, and a third of all cases of psoriasis actually start in childhood. So it's a condition that really needs to be appreciated, understood, and we have to have a plan when we see this during the pediatric years. We are recognizing increasingly that there are multiple comorbidities, and these also exist in the pediatric realm. One of the most important that I'm going to mention to you is psoriatic arthritis. It has the largest evidence base, and if your child has psoriatic arthritis, they should also be seen by an ophthalmologist because they may additionally have uveitis, which is an inflammatory condition of the eye. So arthritis, uveitis can travel together. Keep that in mind. This is a very young baby sent in to see me that reminded me that the prevalence in the United States is about 0.7% of kids having psoriasis. There is some literature that suggests that children have more problems with itching than their adult counterparts. The majority of children, just like this very young child, have plaque psoriasis. There's often a family incidence, and this can be as high as 89%. Now, these are actually my patients, and I want you to recognize that obesity is, while it's quickly increasing in the pediatric population, it may actually play a role in explaining the increased incidence and prevalence of childhood psoriasis. And both the American Academy of Pediatrics and the governor of Texas have actually been involved in programs trying to help control this obesity epidemic, if you will, within the pediatric population. These are additional patients of mine showing you the spectrum of psoriatic disease. It can be very focal, it can be generalized, it can even affect the face more in children than it does in adults. What are the comorbidities that I'm referring to? Well, I talked briefly about psoriatic arthritis, and remember to get your child checked for uveitis by the ophthalmologist if they develop arthritis. But we can also see obesity, we can see high lipids, we can even see associations with diabetes, rheumatoid arthritis, or inflammatory bowel disease. Now, we do need to do screening for psoriasis comorbidities, and this article really sums it up. But the real take-home message I want to leave with you, if your child has psoriatic arthritis, get them to the ophthalmologist, screen them for uveitis. Now, there's also an increased risk of metabolic syndrome in children with psoriasis. Why is that important? Well, we know that if you have metabolic syndrome, you're sort of on the march to diabetes. And we want to do everything we can to stave off that diagnosis because it's complicated and it has many comorbidities that go along with it. And it's not an additional thing we wish our children to bear as they go forward with their psoriasis. So we have to be aware, we have to think about it, we have to do the appropriate workup. We know that psoriatic arthritis in all patients, and this encompasses adults, can occur in 5 to 40% of those with psoriasis. The onset of the disease in the skin actually often precedes the joint disease by as much as 10 years. But we can see a peak onset of psoriatic arthritis between the ages of 9 and 12. And up to 20% of all childhood arthritis that's out there actually is in the realm of psoriatic arthritis. So keep that in mind. We have another retrospective account looking at comorbidities in pediatric patients with psoriasis. And these authors actually emphasized the psychiatric comorbidities. And I want to emphasize for you today, that is not something that should be forgotten about, because the feelings that the child has, but may not yet know how to express them, can be a real key to success in getting them to use their therapy, but also to move forward in life and be successful and be happy. We have many authors who've also alluded to the fact that the psychological impact of psoriasis on pediatric patients really cannot be ignored. And this author really wanted to remind us that we can't just treat the skin in this arena. We have to be more global in our approach. We may not manage all the psychological or psychiatric components, but we have colleagues who can work with us, and we can be a team and help these patients get through this. Now, I think one of the real cornerstones to success in pediatric psoriasis therapy is education. Explain why you're doing it, what the purpose of the medicine is, what the side effects might be. And that's true whether you're using coal tar, topical steroids, moisturizers, or even some of the newer biologic agents. If you have very young children, some of the therapies I still use is, well, first I want to think about, does this child have strep throat? This has been a sudden and precipitous onset. I will use tar in these children, even though it's very old-fashioned. It's over the counter. It works well. We don't see allergic reactions. It's also what we call remittive therapy. They can use tar or tar and light and actually get disease breaks from their psoriasis. Of course, we use topical steroids because they're very quick to help patients see the results of some resolution and involution of the psoriatic plaques. But we can think about the topical calcineurin inhibitors, especially in the setting of inverse psoriasis. That's psoriasis that they might have in the groin or in the armpit. And I still use a good bit of phototherapy. It can be natural sunlight or come in to a light box or get a home light box. If we have older children with psoriasis, we still use the topical steroids or other topicals. We think about phototherapy or even laser therapy. We do have these available in our clinic, but we may need to go on to systemic therapy, including drugs like methotrexate and cyclosporin. And I bring this up because I'm going to talk about the ability of a child to manage that particular set of medicines, which have the potential to cause immunosuppression. We also use retinoids, topical or oral, and again, biologic agents, which are the newest player in the arena of therapy for this patient population. What about vitamin D analogs? Well, we can use these in conjunction with topical steroids. They are mentioned in the AAD guidelines that I'm going to cover in slides that follow. And we know that we can use safely up to 45 grams per week over the meter squared. There's actually no effect on serum calcium levels if we stay within the guidelines, but these agents do cause occasionally localized irritation of the skin. Sometimes mixing these with a little bit of plain Vaseline does the trick, and we can use these medications very successfully. So let's move on to the AAD guidelines for pediatric psoriasis. These are very recently published in the Journal of the American Academy of Dermatology, and I'll just mention, as a member of the American Academy Board of Directors, we actually review these guidelines before they go forward for publication. So I play a role in the evaluation of the text before it goes in the public domain. These guidelines include systemic therapy, as are listed here, but they also really include all the other medications. And we have a very limited spectrum of choices when we think about using biologics or other systemic agents in the pediatric realm. There are actually only 6 FDA-approved medications in all of the arena of therapeutics for pediatric patients suffering with psoriasis. So with biologics, and we've done most of the research on all of these products, we have etanercept, ustekinumab, and izokizumab, which is the most recently approved drug. For topicals, we have a calcipotriene foam that goes all the way down to 4 years for scalp or body, a calcipotriene and betamethasone foam, which is for 12 years of age and older, and calcipotriene and betamethasone suspension, again, 12 years and older. So again, a very limited therapeutic group of medications that are very beneficial, but we need more. And I am working every day in our research to hope we get more psoriatic approval in the pediatric realm. Not long ago, this article, which is a really key publication, looked at the severity, psoriasis severity in patients treated either with methotrexate or with the biologic. And I think this particular publication is really key because it discerned that the biologic therapy was more effective and had fewer side effects than methotrexate. So that's why your doctor may encourage your child to consider a biologic rather than methotrexate for therapy. Now, there are some up-and-coming drugs for pediatric psoriasis, and we're engaged in several of these trials. Some involve secukinumab, which is an IL-23 inhibitor, brodalumab. We certainly participated in the adult trials for this drug. And then tildrakizumab is another IL-23. Now, we have some new topical agents under study, a halbendazole tazarotene lotion. I believe that one may have recently been approved. And really exciting is a new drug, roflumilast, which is a PDE4 inhibitor. The studies will go from 2 to adulthood. You may have heard of this drug used systemically in chronic obstructive pulmonary disease, but we're talking about a topical agent here, not the systemic use for lung disease, the same base, but different preparation. Again, we're talking about topical for roflumilast. So what does all this mean for transitions in care? Now we're going to get into the nitty-gritty of what I really want to talk about. I really want to emphasize you can't give a single age where you can turn over the care of psoriasis to the child. Some children are much more mature at younger ages, and some really are not at all mature even at older ages. We have some adults, we think, that struggle with their therapeutic regimen, but we try to write it out for them and make it as clear as possible. We re-educate when that becomes necessary. But remember that maturity depends on the child, not the age. It also depends a good deal on giving the child more autonomy on the therapy that you're actually administering. And I'll talk about that in some slides that follow. For example, if the patient is undergoing home phototherapy, because it's hard to turn the therapy light on when you have the occlusive eyewear that you wear as a patient, we really think a parent should be there so that they can turn the machine on and off, because this reduces the risk of ocular damage and skin burning. Now, moisturization of the skin. I have a lot of experience with this in terms of children taking on some of the role, particularly in atopic dermatitis. But some children can actually handle putting a moisturizer on, especially if it's in a pump bottle, as early as 5 years of age. Every child is different. As I talk to you, we all know we have teenagers who just cannot get their act together, and they may need more help for a longer time. We're not to be critical of them. I'm going to talk a little bit about brain development in the pediatric patient, because it's a really challenging time of growth in the brain, and that is believed to be some of the reason that teenagers just can't get things done the way we think they should. Now, biologic therapy. If you have a child that's 16 to 7 years of age, and let's say they have a click pen device and they feel comfortable giving themselves a shot, I think that would be something that would be reasonable. But my recommendation is that you should have an adult at home at the time of the injection. Occasionally, patients get an injection, even in the doctor's office, and they faint. And we don't want your child fainting with the needle still in their abdomen or in their thigh, and then nobody's home. I don't think that's a very healthy environment. So I would agree to let them self-administer if they feel mature enough and you feel comfortable with it, but do have an adult available in the home. When can we transfer care when we're dealing with methotrexate or cyclosporin? I don't think it's a good idea until the patient is about 16 or 17. These drugs both have risk of immunosuppression. We are living in the COVID era, and I think we have to monitor these drugs a bit more carefully. On the other hand, folic acid, which is administered at the time we give them methotrexate and every day in the week, that poses little risk. And many responsible teenagers can handle this by age 15 or even possibly younger, depending on the child. How about topical medications? Well, certainly many children 15 years of age and some much younger can handle this. They can apply the topical steroid or the topicals, including the TARs. We do find the girls are better at this than perhaps the boys. So again, work with your child. I encourage you, and the children are little, to talk to them about someday, if you feel you're ready and you feel you can do it, we're going to let you take over applying this medicine directly to your skin. So begin the education process early, just like the same thing for brushing their teeth, driving the car. They need to be sort of taught along the way about effective ways to manage their skin disease. And I think this is one thing they could handle. I think the child has to be ready to take on the responsibility. Again, I mentioned coaching the child on how, when, and why to do the treatments. Always explain the why. That's really important. They need to understand why they're trying to get their skin better. It might not work well the first few times. We know that as parents, many things we have to go over again and again with the child. Always try to offer positive reinforcement when it's done effectively, but re-educate as necessary. And offer the child vacation if they have other stresses. Let's say they've just gone back to school after they've not been in school for a long time. They're worried about COVID. They've missed their friends. All this separation and so forth may stress them. And if they need a vacation, offer that to them and give it to them. I mentioned talking to your child early about when you're applying the topicals or giving them phototherapy or even giving them a biologic, about how you might someday transition so they can learn how to be effective in doing this. Also, always give the rationale for treating. We really want to keep their skin disease under control and reduce discomfort. We want them to sleep better. We want them to be participating in sports. We really want them to have a full life. So why is it so hard sometimes to transition? Well, psoriasis is really a pretty big burden to carry. People can see it. Their scalp may flake, their nails may look abnormal, they may have plaques on their face, and the challenge can be difficult for children to bear. It's often difficult for adults to bear, but I think we have to keep this in mind. Now, we have a number of publications that, while they don't specifically deal with psoriasis therapy, they talk about how to promote adherence with oral agents, and this is really an oncology paper, but I thought there were some great key points, and I want to share some of those with you. First, what is adherence? This is actually defined by the International Society of Pharmacoeconomic and Outcome Research as the degree or extent of conformity to the recommendations about day-to-day treatment by the provider with respect to the timing, dosage, and frequency. It also refers to the duration of time from the initiation of the medication to discontinuation of the therapy. So that's what we mean when we say adherence, sticking to the regimen that the doctor has proposed. I think C. Everett Koop, our former U.S. Surgeon General, said it all when he proposed that drugs don't work if people don't take them. And that's something we want to avoid in this environment where we're trying to get our teenager or adolescent to take over some of their own psoriasis care. We also want to be sure that we provide adequate information, and some of this has to come from the healthcare provider. Provision of information is really considered the cornerstone of patient empowerment. Here is your medicine. This is what we hope it will do for you. These are the potential side effects. This is how you use it. And if you have questions, you can give us a call. The patient really needs to understand their medicine to use it correctly. Now, there are several apps that can be used to remind patients with text to take their medicine or use their medication, and many patients have found these beneficial. I didn't list the apps here, but most teenagers are pretty adept at finding these things on the internet. And then plan ahead for weekends and vacations when reminders may fall off the map or the child doesn't have their cell phone with them quite as much, although most teenagers won't go anywhere without their cell phone, but just keep that in mind. All right, I want to talk about other barriers to adherence with medicine. First, adolescents and teens really just want to be normal and they want to have freedom and they don't like being different than anybody else. If you're the parent of an adolescent or a teen, you've probably already figured this out. Many times, though, patients feel we didn't communicate as their physician as well as we should have. And we're always rushed. Sometimes the questions can be repetitive, but the patient doesn't really understand. So we have to work very hard on our end to make sure there is good communication to better understand the therapy we've outlined. I do want to stress to you as parents, there is some evidence in the medical literature that overly controlling parents really is not a helpful strategy in trying to get kids to initiate and carry forth their own medical care. Also, if there's a lot of family stress, and who doesn't have family stresses, but as much as it can be controlled, I think that's to the benefit of the patient and the initiation of the patient having more autonomy in their own care. We have to also have education about psoriasis as part of the program that we share with patients. And I just want to reiterate the fact that if a patient truly has depression, that can be a significant factor in an inability to carry forward with their own healthcare initiative and doing their own medical care in a way that is going to benefit them significantly. Also, in this particular article, they said that the more complex we make the regimen, the more difficult it is for the patient to comply and actually complete the regimen that we've outlined. Many teenagers and adolescents have trouble with time management. Even some adults, of course, have this same challenge. Also, teenagers often tend to have a good deal of forgetfulness, and we'll talk about that in some slides that follow. We really want to focus on communication. The doctor should always be speaking directly to the patient, even if the parent is in the room. And I want to mention briefly, there's a therapy called motivational enhancement therapy, which really focuses on the patient point of view rather than coercing the patient to change their behavior. And I have some slides on that I'll share with you. Remember that teenage moodiness is very normal. So they may fall off their effective therapy schedule. They forget, they're too busy, they don't want treatment. You have to remain calm as a parent or guardian and consider open-ended conversations like, is this a good time that we might talk about your psoriasis treatment schedule? We find that that's more effective than saying, did you take your medicine today? Because that makes patients feel uncomfortable and defensive. So again, a calm conversation, really just talking about their psoriasis treatment schedule rather than how many doses they missed, etc., is often a good strategy. So remember that if medical treatment adherence is actually carried out, the odds of a good outcome are actually 3 times higher for the patient. So we can remind our children about that. And a lack of adherence, unfortunately, is associated with a poorer quality of life and increased healthcare costs. So some things that will have the treatment work best include a positive family functioning. We hope that's the environment in your home. If the patient has close friends, and we hope that's an absolute for all patients with psoriasis and all kids in general, but also that kids need to develop this internal locus of control. And many kids are taught this in school, but some have a little more challenges in making this happen. They want to have a treatment with immediate benefits. This may be why your dermatologist prescribes some topical steroids along with other therapies, because the benefits often are very quick to see. We also need the benefit of the parent's belief in the seriousness of the illness and the efficacy of therapy. If the parent doesn't have the buy-in, it's really hard to get the kid to buy in as well. So we know that medical treatment adherence is actually worse when there is a mental health issue with the patient or their interface with the doctor. If the patient is very anxious or very angry with the doctor, things often don't go well. If there are family conflicts at home, that often inhibits the ability to conduct therapy the way we would like it to be conducted. If the therapy, as I mentioned, is too complex, or medicines with side effects that really bother the teenager, that's something we need to revisit, discuss, and work on. We often want our children to take over some of their therapy, but keep in mind that teens are at a critical developmental stage, especially with regard to brain development. Adolescence is such an important transition from childhood to teenage years. They have physical challenges, they're at pre-puberty for many of them. They're developing cognitive maturation. They're also developing their identity and the development of independent social relationships. So they really have a lot going on in their heads and in their lives. In the teen years, we see our kids going from complete dependence on the parent to a more autonomous lifestyle. So again, a great time for growth for them. Young teens unfortunately believe what they have seen or experienced, and they cannot possibly fully understand the consequences of not using their medicines the way we would like them. So keep that in mind. It's not always possible for them to undertake what we expect. Adolescents most typically are very self-centered, and they feel invulnerable to the consequences of not taking their medicine. So remember this. They also believe that negative things only happen to others, and we should keep that in mind as well. Adolescents really don't understand risk assessment skills, and they have lack of impulse control, and they have poor organizational abilities. They're developing these, but they're not fully ready to take on a really complex medical regimen. Teens really struggle sometimes to incorporate a medical condition in their evolving sense of self. They basically don't want to have it, but that's not going to change the landscape, and we've got to work with them to make them accept and move on. We understand that teens may feel, if they have psoriasis, that they feel powerless, and they really try to gain control in some way by actually not taking or using their medicines. So be aware that it's a bit of a power issue more than using medication issue. Some teens even perceive a benefit from non-adherence. They may say, well, I have fewer side effects and I have a better schedule. They're not really thinking about their psoriasis as much. Also, not taking their medication may be a strategy to get attention from parents or caregivers. That may seem far-fetched, but that's what the literature suggests for us. A little bit about the MD who cares for your child. Teens really prefer a doctor who's not judgmental, who's very honest and expresses concern, empathy, and respect for both the patient and family. I always try to do that when I talk to my patients and their families. Really, we want to show that we take their condition seriously, and we're really going to work with them, even if it's a long-term management plan, which it almost certainly will be if you're dealing with psoriasis. We also want to be able to recognize that the teen is, in their mind, the expert of his or her own life and their priorities, and we have to think about that. We are aware, and whether this is psoriasis therapy or acne therapy or any other therapy, most teens find it easiest if we've left their medicine out with, let's say, where the food is, or let's say we link it to something else they're already going to do, such as eating dinner or brushing their teeth. So they're going to be more compliant if we pair it with something they're doing and we make the medication visible. So just think about those tactics. And we use this across the spectrum of dermatology in treating our teenage patients. It's really important to be non-judgmental, treat these patients with warmth, respect, empathy, curiosity about the adolescent's view, humility, eagerness to learn more about their perspective. And what I'm talking about is this motivational enhancement therapy. This really is something done with the doctor, and not every doctor may know about it. There is an effort to explore and accept and try to understand the adolescent's view rather than, again, coercing them to change their attitudes and behaviors and their flexibility. Motivational enhancement therapy does take time, but it helps the adolescent really focus on the reason for low adherence. And it's really based on the adolescent's own readiness to change. And this, again, takes time. So just a little bit about the 5 stages of motivation that teenagers have. And again, these are used as part of the motivational enhancement therapy because you have to understand where the teenager is in this scheme to direct the therapy accordingly and to direct this enhancement therapy appropriately. So in pre-contemplation, they really deny they have a problem. In contemplation, okay, they know they have a problem, but they're not in need to change and actually start their medical therapy on their own. In the preparation phase, again, they've acknowledged the need to change, but they're really not yet ready to invoke that change. Action, well, they're ready to get your help so they can start to undertake some of their medical regimen. And then maintenance, they really want help to maintain the changes. So when I talk about this, I mean getting a vacation every now and then. Just a reminder that their medicine is put on the table where they eat breakfast or dinner so they can see it. A reminder, perhaps a post-it note on their mirror where they're going to brush their teeth. Just little gentle reminders to help them along. So this is another paper that's in the medical literature looking at how to get adherence enhancing interventions in the realm of long-term medications when one is treating adolescents. And I've mentioned this article before, and I've quoted some of the key points and pearls that were shared. So a few other tips that are very general, but I want to share these with you because I've certainly used these in my clinic. If you have a female patient and they're very stressed about their psoriasis, sometimes if they're moody during their periods, we will suggest that they start on a birth control pill. This often reduces the menstrual moodiness and the discomfort. It makes the periods lighter, usually after the first menstrual cycle. And then if they have a lot of nail disease, you can consider getting them a manicure, and they can wear polish over their nails if that's allowed in their school. I also want to draw your attention that many teenagers, of course, have acne or atopic dermatitis or other conditions. Don't hesitate to bring this to the attention of your dermatologist. Our acne patients really have something we can treat. We also have drugs that are very effective, even curative in the acne realm. We're also getting better drugs in atopic dermatitis, and patients can have atopic dermatitis concomitantly along with psoriasis. So have your dermatologist address those issues as well, and your teen often will feel better. The psychological challenges that the parent doesn't feel they can handle, really, I encourage you to seek professional help. There are some online apps and counseling available now, and you can pay as you go, and the cost is fairly reasonable. It is harder to get in probably to see a psychiatrist or a psychologist right now with COVID, but I encourage you to consider it. I want to mention that the American Academy of Dermatology sponsors regional summer camps. They were on hold this summer because of COVID. I've sent many, many children to camp across the years, and often children come back with a better sense of self-esteem. These kids can go to camp as young as 8. It is overnight camp. It's 1 week. Your dermatologist has to fill out the forms, which are available on the American Academy of Dermatology website, and there is no cost to attend these camps. The cost is covered. They do have pediatric dermatologists and dermatologists there and nurses that help care for the children with skin disorders that need that ongoing care. But it's really a wonderful opportunity for a child to grow personally, spiritually, and get a lot of friends. So back to the guidelines that were published in the Journal of the American Academy of Dermatology. Again, these were co-sponsored by the AAD as well as the National Psoriasis Foundation. And these really represent the first published guidelines in the realm of pediatric psoriasis. So we're very pleased about these. And one of the things the guidelines did address was severity measures, the triggers and comorbidities, some of which I touched on, and then our treatment options, which include, as I mentioned, topicals, phototherapy, non-biologic systemics, and biologic agents. And keep in mind that it's really important that these guidelines really identify the care that the child can receive, that psoriasis in the pediatric realm is different than in the adult realm, and we need to think about age as a consideration when we choose the therapy for these particular patients. These treatments should be individualized, but they all should be effective, and we really do want to involve the child as much as reasonable in that decision-making process. Remember the ongoing education, because the child's needs will change over time as the child grows up.
So it's now time for the Q&A. If you have any additional questions based on what you've just heard, please submit them now through the questions panel on your attendee interface. We'll attempt to answer as many questions as possible in the remaining time. So Dr. Hebert, one of the questions that came through, what advice do you have for a 13-year-old with pustular psoriasis?
Okay, well, I certainly have taken care of my share of patients with pustular psoriasis. I guess the first thing to do is get a really caring, available physician to work with you. I would say in my experience, I often start with cyclosporin because it's the quickest to have onset, and then I'll transition often to a biologic agent or to acitret, which is a retinoid. It depends on how the patient is done and how they have responded before, if they've had any therapy. I think it's really important to reduce the stress for this child, to look for the triggers, whether it's strep. I have literally taken children out of school and done homeschooling if they have stress at school and they just can't function in that environment. But whatever it takes, we'll do it. We also do wet wrap therapy on these patients to get them better quickly. One other product that I'm going to mention by name is called Enstelar. When you spray it on, it is a very cooling sensation and often gives a lot of comfort to patients with pustular psoriasis or erythrodermic, meaning very red skin psoriasis. So that's what I would engage in. But you do really need to get attention quickly because these patients often feel bad in the moment, and you can be fine in the morning and at 2 o'clock in the afternoon be covered with little pustules related to pustular psoriasis. So it really warrants rapid attention.
And another question, how will psoriasis affect my 15-year-old son mentally when he grows up?
Well, ideally, your child will have good family support and lots of close friends. Certainly, it is a burden for your child, but I will say, as we are getting more medicines with better efficacy and good safety, I would certainly encourage your child, if he has widespread psoriasis that is more than 10% body surface area, to consider using one of the approved drugs within his age range. But also, if he's a candidate for biologic therapy, to consider that. We seem to be getting the best results, at least currently, with our biologic agents across the spectrum of psoriasis. We are now have drugs where getting something called the PASI 90 that is controlling 90% of the patient's psoriasis is very doable with rapid onset. It's a very exciting time to be a dermatologist because of the new therapies that we have in our armamentarium that could really help patients tremendously. But a 15-year-old with psoriasis needs a very caring physician. And I hope that you have all of these components, because it's not just one thing that will make his transition into adulthood better and more successful. It's really a constellation of events, medicines, and care that will ensure that he goes happily forward in his life.
And if a teenager is on a biologic, is he or she more likely than an adult to find that it stops working for them in a year or two?
I don't believe that there is evidence to suggest that we have poorer sustained efficacy in the pediatric realm than the adult realm. But let me make one key point. If you're trying to stretch out your, let's say, TNF, and the TNF that we have approved in the United States is known as Enbrel, you may get less efficacy because the TNFs tend to lose some of their efficacy if we don't use them according to the directions. Now, we know with Enbrel, a patient has to get 2 shots in a week. It's a lot of shots. The medicine works well, but if you start to stretch it out, unfortunately, you will have a fall off in efficacy that may not be able to be gained back. This is unfortunate, but it has been observed both in the pediatric realm and in the adult realm, so we have to keep that in mind. And I think that we are learning more about the recurrence or relapse in our clinical trials over time of given drugs, both in the pediatric and adult realm, but we are getting better sustained control. And ustekinumab, which is one of the drugs approved for children in the pediatric realm, you only have to take a shot 4 times a year. And so it's often easier on the patient. It's a very reliable medication, and it has a very good ability to help control psoriasis.
Another question, are lifestyle factors ever addressed as complementary or alternative care for youth that have psoriasis?
Well, one of the things that I always talk to the parents and the child about is if the child is doing sports, we want to have good protective gear. Let's say the child is playing softball or basketball or volleyball. I always want them to try to wear knee pads and elbow pads, because these are the areas with psoriasis that are often very visible. So it helps with the psychosocial, but it also reduces the Kebner effect. When we traumatize the skin, we tend to get psoriasis in those areas, and your dermatologist will call this the Kebner effect. It's named after Dr. Kebner, who had psoriasis and had trauma, and he described it, and his name sticks with that phenomenon. So I do think that we do talk about lifestyle in terms of sports. In terms of holistic medicine, if it helps the child be more calm, I'm okay. I have some reservations about some of the Chinese herbal medicine, only because some of those medications contain systemic steroids, which can result in a quick improvement in psoriasis, but an explosive and even worse psoriasis on return. So I do caution parents about that. But if the holistic system seems to be helping the child, I don't have a problem with it. I give caution sometimes because we see those who take advantage of families when there's no cure for a disease, and they charge many thousands of dollars, and it really isn't therapy that's going to cause benefit. It's just to profit the holistic medicine physician. So a word of caution there is what I share.
And do you have any tips to help control scalp psoriasis?
Scalp psoriasis can really be tough. So I'm going to give you actually some name brands and some tips we have on our shampoo handout. One of the things you need to do is if you're using a dandruff shampoo to help your child's scalp psoriasis, is you need to rotate between different chemical classes. So I'm going to name some of these chemical classes and you have to read the labels. There's salicylic acid is one class, and T-Sal, a Neutrogena product, is one example. There are tar products, and Neutrogena makes a tar shampoo. I'm not particularly favoring one brand over another, but I'm giving you concrete answers. Then you want to look at your zinc pyrethroid group of products. A lot of the Head and Shoulders categories fall in that arena. There is a product called PNS, P as in Paul, S as in Sam, that makes a solution that you can buy over the counter, and you leave it on the scalp overnight, and then there's a PNS shampoo that you use to wash it out. That's a great product to use. In addition, there are some products like Kenalog spray, which sort of looks like a WD-40 can with a little straw where they can spray the scaly parts of the scalp. We also have topical steroids designed specifically for the scalp that can greatly reduce the scaling. I want to caution individuals about pulling all the scale off. I talked briefly about the Kebner phenomenon. And if you're vigorously scraping that scalp scale off, you're likely to pull out some of the hair, but you're also likely with the trauma to further the development of psoriasis on the scalp region.
And how do you balance hormones since psoriasis gets worse during that time?
Well, there are many challenges trying to balance hormonal influences. We have this same discussion with acne. Again, if the parent is willing and if the child is amenable and they've already had their first period, we can sometimes for the women balance out the hormones by using birth control pills. We do this in acne. There are several FDA-approved birth control pills specifically for acne, and they work very well. We consider the birth control then a side effect of the medicine, not the primary reason we pick it. Less able are we as clinicians to manage the hormonal effects that the boys experience because we really don't have medications that can help target that. And it's true both in acne as well as in psoriasis. So I think teaching good self-control, teaching them maturity as much as we can, emphasizing their feelings, as I mentioned in several of my slides, working with them, teaching them at a young age, encouraging them to initiate some of their own therapy if you feel comfortable and they're ready. I think those are all important factors, but we don't have a perfect modality for hormonal changes during the teenage years, whether your child is a girl or a boy.
And another question, what in your opinion is the best medicine for psoriasis nowadays?
Well, I can't say that there's a single best medicine. I'm very impressed with some of the medications that are in the pediatric realm. That includes ustekinumab as well as izokizumab. Both of these are very effective biologic agents and again have FDA approval. I'm still a big fan of Enbrel, and many times with step therapy, the insurance makes us go through Enbrel before we can go to one of the other medicines. I think these are excellent. I also think the calcipotriene agent, which is steroid-free and FDA approved in the pediatric realm down to 4 years of age, is an absolutely wonderful medicine to consider because you have no real limitation in time on its use. The two other topical agents, which include a calcipotriene and a betamethasone, can also be very helpful in managing your child's psoriasis. There are biologics on the horizon that are just amazing. I've worked on some of the adult psoriasis trials, been very impressed with the medications that are available to the adult population. I know several new medicines that are available in the adult realm are poised to soon be available in the pediatric realm as well, so stay tuned. Again, I don't think there's a single best medicine. I mean, I have my personal favorites. Your physician, though, may be a little bit hands tied behind their back. It's going to be really what your insurance will cover, and that varies by the different carriers. Sometimes we have to choose what the insurance will cover and do our best with that medicine at that time.
And one last question. So would you say that biologics are appropriate for children?
I have to say, as someone who did indeed do the Enbrel clinical trials, I think there is a time and a place when a child is suffering or getting arthritis where we certainly should consider a biologic. Your physician needs to consider every case independently, but I think a child who is suffering, who has at least 10% body surface area, may be an excellent candidate for a biologic. It doesn't mean every patient is willing or able to tolerate a biologic, But I certainly think children sometimes get undertreated because they are children. I think that's very unfair. I let the child tell me many times how they feel about a medication. Now that we have biologic agents in atopic dermatitis, I have 6-year-olds coming in and actually asking if I think it would be helpful to them. They see these drugs on TV and they really want to know if they could benefit. They want to get better, and they simply have scientific questions. So every child must be considered individually, but I am personally one who will treat more aggressively, especially if the child is suffering or if they've tried other modalities, either from me or from the referring dermatologist, to try to get them to live the best possible life and have the fewest side effects and the lowest risk for developing arthritis.
That's a great perspective and a great way to end our webinar on today. So thank you, Dr. Hebert, for taking time to answer the questions we received today and for sharing your expertise about transitions and care responsibilities for youth. We really appreciate all of your efforts today.
Well, thank you, Bev, and I thank everyone who attended, and I hope this information was helpful.
Oh, definitely. For resources specific to youth and you as a parent, please visit our spot at psoriasis.org/our-spot. Resources include age-appropriate information up to age 18, personal stories, access to ordering a welcome kit, which includes a booklet specifically for teens or ages 12 and under, school resources, and more. If you'd like to connect with other parents who have a child or teen with psoriasis and/or psoriatic arthritis, contact the Foundation's one-to-one program to speak with a trained volunteer who can offer the information you need. To start, simply complete the match form at psoriasis.org/1-2-1. In addition to today's webinar, podcasts about the guidelines are also available as listed on the screen through Apple Podcasts, Google Play, Spotify, iHeartRadio, or a feed service of your choice. You can access podcasts at the website listed here. If you'd like more information about the AAD Pediatric Treatment Guidelines, you can catch Dr. Laura Weinle with episode number 50. Or if you need tips for making telehealth visits successful, try episode number 83 with Dr. George Hahn. You can also listen to the story of Eddie and Zach Harrison, Psoriasis is Just Part of Who I Am, with podcast number 70. Contact the Patient Navigation Center, the world's first personalized support center for people impacted by psoriatic disease. If you still have questions, would like additional information about treatment options, need help finding a physician, or are having issues with accessing treatments, contact our Patient Navigation Center by phone or email as indicated on the screen. You can also contact the Navigation Center to ask about connecting with others who have psoriatic disease, as mentioned through our one-to-one program. Reach out at education@psoriasis.org or call 800-723-9166, option 1. Once you leave today's webinar, you'll receive a survey to provide feedback about the presentation. Tell us what you think. We value and appreciate your comments. Thank you again to our sponsors, Amgen, Janssen, Lilly, and Novartis, for their support of today's webinar. Finally, you can access our webinar archive at psoriasis.org/watch-and-listen. This concludes our presentation for today. Thank you for attending.